Hello, this is again Professor Nick, PA from Physician Assistant from Brooklyn, New York. Today is Monday, March 21st, 2 o'clock in the afternoon. This slide, number one, shows the treatment for shoulder dystocia, which is number one, Macrobius maneuver. This is a first-line treatment. It means that the mother flexes the knees into abdomen with suprapubic pressure. Then the second one, this is Robin's maneuver. Robin's maneuver is when you have rotation of the fetus shoulders by pushing the posterior shoulder towards the fetal head. Then number three, this is Wood's maneuver. The Wood's maneuver is when you have the rotation of the fetus shoulders by pushing of the posterior shoulders towards the fetal back. Number four, you have is when you have delivery of the posterior arm. Number five, when you have deliberated fracture of the fetal clavicle. And you have number six, the Vanetti maneuver, when you push the fetal head back into the uterus and perform cesarean section. This maneuver is related to a high both maternal and fetal mortality. Let's go to the next slide. This slide talks about postpartum complications, and the first one is uterine inversion. This is a very rare complication, and it's basically obstetrical emergency. Inversion occurs when the fundus collapses into the endometrial cavity and turns inside out. This is related to excessive umbilical cord traction and fundal pressure during stage 3 of labor. We have some risk factors. We'll mention the first three. Macrosomia, number one. Number two is rapid labor and delivery. And number three, short umbilical cord. Additionally, we have uterine abnormality in placenta correcta. Then we have a clinical manifestations. It manifests with number one, vaginal bleeding, number two, with lower abdominal pain, and number three, with smooth round mass protruded from the cervix and vagina. It is based on the diagnosis is based on clinical presentation. The treatment for uterine inversion. Clearly, the treatment is to return the uterus back to its correct position. This can be accomplished by several means. Number one, we have to stop all the uterotonic drugs. We need to have the uterus relaxed and return to its proper position. Number two, manually, we need to reposition the uterus. If this repositioning is not possible with manual maneuvers, we need to Try uterine relaxing agents such as nitroglycerin. Let's go to the next slide. Slide number 3. Nitroglycerin, terbutaline, and magnesium sulfate. If all these fails, we need to do laparotomy to reposition the uterus. Another complication is lactational mastitis. Basically, this is inflammation of the breast with fever, myalgia, pain, and erythema. Could be two types, infectious and non-infectious, and it can usually occur in the first 6 weeks of postpartum. Diagnosis is based on clinical presentation. The treatment usually requires digoxin and or cephalexin, also anti-inflammatory and cold compresses. Breastfeeding can continue. The next complications, this is postpartum blues and depression. The postpartum blues are transit condition which starts 2-3 days after delivery and resolves within 2 weeks. It appears that is related with a level of the hormones and changes. It characterized with sadness, tearfulness, anxiety, insomnia, and decreased concentration. The risk factors for this are family history of depression, number 1. Number 2, depression symptoms during pregnancy. Number 3, history of PMS or PMDD. And number 4, stress surrounding the child care. Treatment for postpartum blues are not needed. It is self-limiting. However, if progresses, it can lead to postpartum depression. Let's talk about risk factors for postpartum depression. Number 1, depression in the past. Number 2, history of abuse. Number 3, young age. Number 4, unplanned pregnancy. And number 5, stressful life events. Let's go to the next slide. Slide number 4. Here we'll continue with risk factors for postpartum depression. This is no partner or intimate partner violence. Then next is gestational diabetes. Then next is no breastfeeding, and the last one is miscarriage and stillbirth. The clinical presentation for postpartum psychosis. We need to know that postpartum psychosis is postpartum depression plus delusions, hallucinations, and disorganized thoughts and behavior. Also, we need to know that it can have anxiety and panic attacks, irritability and anger, inadequate feeling and overwhelm with taking care for the baby, feeling of failure as a mother, and fear of hurting self or the baby. Also, we need to know that many of these symptoms of postpartum depression overlap with the effect of being a new mom, such as fatigue, trouble sleeping, and low libido. It's very hard to distinguish between the two. Women are often reluctant to ask for help. And the last one is diagnosis and treatment of depression. Like treatment for postpartum patients are the same as for the general population. The end of this slide talks about postpartum hemorrhage. By definition, this is bleeding more than 500 cc after delivery. Early postpartum bleeding occurs within 24 hours, and late postpartum bleeding after 24 hours to 6 weeks later. Let's go to slide number 5, which is the last slide. Etiology is usually postpartum. The uterine contractions compress the blood vessels to stop the blood loss. Uterine atony accounts in 80% of postpartum hemorrhage. Other causes are like lacerations, retained parts, and/or coagulopathy. And the meaning of the word uterine atony is A, without tony contractions. The risk factors for atony is number 1, anesthesia, number 2, uterine overdistension, such as twins or polyhydramnios. Here there is a clinical tip that Sheehan syndrome after postpartum hemorrhage presents with inability to breastfeed. Also presents with prolonged labor, laceration, retained placenta, and coagulopathy. Treatment is we need to examine the uterus by manual examination, assure that there is no rupture of the uterus and that there is no retained placenta. If the examination is unremarkable, by manual compression and massage should be done. This will not control most cases of postpartum bleeding, and if the manual massage does not control the postpartum bleeding, administer oxytocin to make it the uterine contract, constricting of the blood vessels and decrease of the blood flow. And this is the end of this chapter. Once again, this is Professor Nick, physician assistant from Brooklyn, New York. Thank you so much. And if you have any suggestions or comments, please email me at nickm like Mary, D like dog, the number 1 @gmail.com. Thank you.